All right, we have our next presenter, Dr. Thomas, who was my DNP student. Dr. Lasoria Thomas is going to talk about decreasing falls among older adults in Med-Surg unit by implementing the Johns Hopkins Risk Fall Assessment Tool. Welcome, Dr. Thomas.
Good afternoon, everyone. Please excuse my raspy voice. I'm just getting over a cold. First, I would like to thank Dr. Ralston for allowing me the opportunity to implement my project on Nursing Station 61. I would like to thank Dr. Shea for being my mentor. She was very instrumental in, giving me information and showing me, a few things here and there to be able to be at this point. And Dr. Roberts was my biostat teacher. Thank you. That was so instrumental for me to utilize all my skills in terms of research. It was very difficult, but I managed to pull through. I'd rather do this. Okay, so one of my passion is to prevent falls. I always say, most times patients falls is because of something that we didn't do. Most times they're preventable, and sometimes they're not preventable. So I chose to do this one because on Nursing Station 61, we had quite a few falls, and an average of maybe 2 per month at the time when I was looking to try to do this project. So my project was launched in 2023, and I finished in 2024. So in the United States, 700,000 to 1 million falls are reported in the hospital annually. Negative impacts of falls includes injuries, extended hospital stays, or even death. The identified problem is increasing incidence of falls in the medical surgical unit despite using the Morse Fall Scale. The Morse Fall Scale is the scale that we're now utilizing on Nursing Station 61, and what the issue that we're having with the Morse scale is that it's not so definitive as the Johns Hopkins Fall Tool. It's very broad and it's not patient-specific, so we tend to have an inconsistency in assessment and documentation depending on the shift, depending on the nurse. And so we realized there was an opportunity that we can pilot this new fall tool, which is the Johns Hopkins, which is more patient-specific, and it takes out the guesswork out of assessing if your patient is really at risk for falls. We implemented the project on Nursing Station 61 for 2 months, and we had a decrease of a 66.7% decrease in falls. And to me, that was a success, because I was going for at least 50%, and we superseded that. So we're hoping, Dr. Ralston, that we, in the future, change is good. In the future, we can actually look into this tool. The Johns Hopkins Hospital is utilizing it, and because they had an issue as well, and they also decreased falls and also falls with injury. So I think this would be a good tool to also utilize in our setting. So I know we would have to, move it to Epic and so forth, and with the approval of Dr. Ralston, to get this at some point in the future to implement this on all our units with the sole purpose of decreasing falls and increasing patient outcome. Sorry for being nervous. Thank you so much.
Lasoria, right off the bat, will you tell us a little bit about the difference between the Morse Fall Score and the Johns Hopkins Fall Score?
Okay, so with the Johns Hopkins, it gives you specific instances. Like it would ask question if your patient is on any tether, like Foley's, IV lines, SCD stockings, things like that. And with the Morse score, it doesn't say that. It just says IV. If you have an IV line, it gives you a score. And then we realized most of the patients who were assessed using the Morse, they were all high risk. So we were like on high risk burnout on Nursing Station 61. This tool enabled us to really zone in on those patients who were high risk, and we had more resources and time to do the hourly rounding and implementing the bundle, which helped.
Thank you.